Good afternoon. My name is Ulf Beier. I'm a pediatric nephrologist at the Children's Hospital of Philadelphia. I do not have any disclosures. I thank you for the opportunity to talk to you about renal manifestations of mitochondrial disease as part of the Precision Mitochondrial Medicine seminar. Very recently, my esteemed colleague Dr. Rebecca Ganetsky, whom you have heard speaking about genetic diagnostics in mitochondrial disease this morning, held a fantastic grand rounds talk about mitochondrial diseases to the nephrology division. Today, I will approach this topic from the other side. I would like to begin with a review of the biological functions of the kidneys, as it is a good starting point to understand what happens when different aspects of renal function go missing. About 20 to 25% of the cardiac output is committed to renal perfusion. Most of the blood flows to the renal cortex, where it passes through filtering units called glomeruli. Inside the glomeruli, depicted on the upper right, a pressure gradient allows blood to filter out primary urine, which is released into Bowman's capsule. The barrier between the blood and urine spaces is formed by specialized cells called podocytes. The podocytes form a fine mesh, which allows water, electrolytes, and waste products such as urea to pass into Bowman's capsule, while large molecules such as albumin and antibodies, as well as red blood cells, are held back. After leaving Bowman's capsule, urine passes through the tubular system. Here, nutrients, but also water and electrolytes are reclaimed. A lot of the transporters that facilitate these processes are ATP dependent. Proximal tubular cells, which line the tubular system closest to the glomeruli, are particularly mitochondria rich. The proximal tubule is responsible for reabsorption of glucose, amino acids, potassium, phosphate, and hydrogen carbonate. The kidney is responsible for controlling acid-base and electrolyte balance, which can be negatively affected in a number of mitochondrial diseases. The kidneys are important regulators of blood pressure. Through filtration and reabsorption, they control how much water and salt is retained by the body. In addition, renin, a protease secreted by specialized cells in the juxtaglomerular apparatus, can increase blood vessel tone through several mechanisms. Vitamin D undergoes two hydroxylation reactions prior to becoming activated. First, the 25-OH reaction, which occurs in the liver. The second step is the alpha-1 hydroxylation reaction, which occurs in renal tubular epithelia cells. This reaction produces active calcitriol. Calcitriol enables calcium and phosphate uptake from the gut and is critical for the incorporation of calcium and phosphate into the bone. Patients with chronic kidney disease often have insufficient calcitriol. Calcium is critically important for the heart and brain to properly function, and thus several fail-safe mechanisms exist to compensate for insufficient calcium levels due to vitamin D. Low calcium triggers parathyroid hormone, which rips calcium out of stores in the bone to stabilize blood calcium levels in the short term. However, over time, this process demineralizes and weakens bones. This is the reason why patients with chronic kidney disease often develop secondary hyperparathyroidism, renal bone disease, and failure to thrive. Last but not least, the kidneys are also important for blood production through transcription and translation of erythropoietin in interstitial fibroblasts in the renal cortex. Erythropoietin gene expression is triggered by hypoxia-inducible factors and stimulates red blood cell development. Patients with chronic kidney disease often develop anemia. The following table is adapted from a review by Josef Finsterer from Austria and Fulvio Scorza from Brazil. On the left, you will notice abbreviations of different mitochondrial diseases, such as MELAS, Kearns-Sayre syndrome, mitochondrial depletion syndrome, Leigh syndrome, primary coenzyme Q deficiency, X-linked sideroblastic anemia, and others. The table illustrates several interesting observations. First and foremost, a common feature of several mitochondrial diseases is renal tubular acidosis. Perhaps this is not unsurprising, given the importance of mitochondria for ATP production, which is required for active electrolyte transport, which drives bicarbonate reabsorption in the proximal tubule. Second, some renal disease manifestations, such as nephrotic syndrome, which is a condition in which proteins are spilled through a dysfunctional glomerular filter from the blood into the urine, are less common and not a universal feature of mitochondrial dysfunction. Here, specifically coenzyme Q deficiency and nonspecific mitochondrial multi-organ disorder syndrome stand out. In contrast, other conditions, such as X-linked sideroblastic anemia, barely cause any type of renal disease that one would typically associate with ATP production. In this condition, renal damage is caused by iron overload, which, over time, also damages the liver and heart. I will now talk about the individual renal problems that can be seen in the different mitochondrial diseases. As mentioned when we looked at the table, renal tubular acidosis, or RTA for short, is the most common problem associated with mitochondrial diseases. Similar to acidosis that is caused by diarrhea, renal tubular acidosis is commonly seen with a normal serum anion gap. This is due to the primary problem not being an acid that is being produced, such as lactic acid, but rather due to the problem with reclaiming bicarbonate or acidifying urine. There are four types of renal tubular acidosis. RTA type 1 is characterized by a failure to secrete protons into the urine. Typically in distal type 1 RTA, the urine pH is elevated because of this problem. Type 1 RTA can also be identified by measuring urine electrolytes and calculating the urine anion gap. While the serum anion gap is used to look for the presence of an unmeasured anion, such as lactate, the urine anion gap is used to look for an unmeasured cation, ammonium. Ammonium is utilized to trap secreted protons in the urinary lumen. Under physiologic conditions, urine sodium and potassium together should be less than the urine chloride due to the unmeasured ammonium. The physiologic urine anion gap should therefore have a negative number. When distal tubular acidification fails, the ammonium concentration will fall, and thus the urine anion gap may become neutral or positive. This indicates type 1 RTA. Renal tubular acidosis type 1 is often associated with calcium-based kidney stones due to the alkaline urine, as well as calcium dissolution from the bone. Type 2 RTA is due to a proximal tubular dysfunction. Here, the difficulty is not the failure to acidify the urine, but rather an inability to reclaim sufficient bicarbonate from the urine. In contrast to type 1 RTA, the urine is typically not alkaline, and the distal tubule is still functioning and can compensate partially by acidifying the urine. Type 2 RTA is commonly seen in premature infants with immature tubules. Type 3 RTA is a combination of type 1 and type 2. It is very uncommon. Type 4 RTA is due to decreased aldosterone activity, either insufficient aldosterone production or resistance to aldosterone. Aldosterone's physiologic effects include distal urine acidification, salt reabsorption, and potassium excretion. Conversely, with type 4 RTA, the serum potassium is typically increased. Renal Fanconi syndrome is characterized by a global proximal tubular dysfunction. This includes type 2 RTA, as well as a number of other problems such as the spilling of glucose and amino acids into the urine. Other electrolyte abnormalities typically seen with this problem are potassium and phosphate wasting. The diagnosis of Fanconi syndrome is laboratory-based. Glucose can be picked up on the standard urinalysis. However, low potassium and phosphorus do not necessarily need to be due to renal losses, and could come from gastrointestinal losses or intra-extracellular shifting. To discern if the kidney is spilling potassium and phosphorus, it is possible to calculate a transtubular potassium gradient, TTKG, and a tubular reabsorption of phosphorus. The TTKG and tubular reabsorption of phosphorus are based upon fractional excretions and are meant to test if the kidneys are part of the problem or part of the solution. Specifically, how do the kidneys respond to low blood potassium and phosphorus? Do they preserve potassium and phosphorus as they should, or are they unable to hold on to these electrolytes? The treatment of Fanconi syndrome primarily consists of supplementing the lost electrolytes and bicarbonate. Of note, renal Fanconi syndrome is not associated with the Fanconi anemia. Bartter syndrome is a condition in which salt reabsorption in the ascending loop of Henle is disturbed. This leads to an activation of renin-nitrodosterone, which leads to alkalosis but without the typical hypertension due to the renal salt wasting. The pathophysiology can be similar to chronic Lasix overdosing, though there are a number of different genetic defects due to which this condition may arise. Bartter syndrome was observed in some patients with Kearns-Sayre syndrome, where the patients developed an alkalosis rather than an acidosis, along with their renal disease. It is thought that the relative involvement of different sections of the renal tubular system is important to which phenotype of renal abnormality develops. As mentioned in the overview slide earlier, it is possible for mitochondrial disorders to cause a variety of other renal diseases, not just renal tubular acidosis. A particular striking example are the primary coenzyme Q deficiencies. Genetic defects in coenzyme Q monooxygenase and AARF domain-containing kinase 4 are monogenetic forms of steroid-resistant nephrotic syndrome, nephrotic range proteinuria, and focal segmental glomerulosclerosis. Mutations in these genes, abbreviated as CoQ6 and ADCK4, cause the podocyte, that is the cell that forms the filter structure in the glomeruli, to not properly function. As a result, biologically important proteins slip into the glomerular slit diaphragm filter and leak into the urine. This causes a number of different problems for these patients. Albumin is the most abundant protein in the blood. One of its key functions is to provide the blood's oncotic pressure. That is, it is present only in the blood and not in the surrounding tissue, and thus binds water into the blood vessels. When albumin is lost into the urine, the oncotic pressure falls, and water leaks into the surrounding tissues. Clinically, patients develop edema and ascites. Another important protein lost in nephrotic syndrome is antithrombin 3. Its loss makes it harder to prevent blood clots. Combined with a loss of intravascular volume due to low oncotic pressure, which increases the hematocrit, this makes patients with nephrotic syndrome vulnerable to developing a thrombotic event. In addition to albumin and antithrombin 3, another group of key proteins lost in nephrotic syndrome are immunoglobulins. This makes it more difficult to fight infections and especially encapsulated bacteria. For this reason, patients with nephrotic syndrome get additional antipneumococcal vaccinations. Primary coenzyme Q deficiencies lead over time to progressive focal glomerulosclerosis and renal scarring. This leads ultimately to a decline in renal function, chronic kidney disease, and at the end, renal failure. Unlike other forms of nephrotic syndrome, such as minimal change disease, this condition does not respond to steroid therapy. Patients with Kearns-Sayre syndrome and mitochondrial depletion syndrome can develop nephrocalcinosis, which means calcium deposition in renal tissue, as shown on the CT scan on the right. When taking care of mitochondrial patients with renal involvement, the following labs are of particular interest in the assessment of kidney function. The comprehensive metabolic panel covers electrolytes, acid-base balance, blood urea nitrogen, and creatinine. Creatinine is useful to determine glomerular filtration. As creatinine is derived from muscle cells, it can sometimes be misleading in patients with low muscle mass and may make the renal function of these patients appear better than it really is. To circumvent this problem, nephrologists will often also look for cystatin C, another marker good for the evaluation of glomerular filtration. Cystatin C is muscle mass independent. Vitamin D and parathyroid hormone are important to assess for secondary hyperparathyroidism and renal bone disease. A CBC is useful for screening for renal and other forms of anemia. Last but certainly not least, a standard urinalysis or office urine dip are incredibly useful when screening for protein and or glucosuria, as well as for measurement of urine pH, which is important in patients found to be acidotic. On the right, I have listed a number of follow-up labs, mostly with regards to fractional excretion and in response to the workup of individual renal problems. There are a number of interventions to the renal problems that can occur in mitochondrial diseases. These depend upon the specific problem and may aggravate other renal problems. For example, a patient with renal fanconi may be on potassium supplementation, and a patient with proteinuria on an ACE inhibitor. Both could be detrimental when renal function is impaired, and this requires careful adjustments depending upon the clinical situation. Sometimes, patients with mitochondrial disease will develop renal failure and require renal replacement therapy, that is peritoneal or hemodialysis, or a kidney transplant. An important point that I would like to make is that patients on renal failure should never get gadolinium contrast for an MRI. This is due to the risk of nephrogenic systemic fibrosis. Nephrogenic systemic fibrosis is a dangerous and potentially fatal condition, and dialyzing the contrast off after the imaging may unfortunately not be enough to help affected patients. If an MRI with contrast imaging is essential, iron-based contrast, such as ferrimoxetol, may be an alternative. For those patients that require dialysis, it is important to note that peritoneal dialysis, which has several advantages over hemodialysis, especially in children, does come with an extra lactate burden. Especially patients with insufficient NADH dehydrogenase may be unable to properly oxidize the lactate to pyruvate. In summary, we have reviewed that mitochondrial diseases can cause a variety of different renal conditions. While renal tubular acidosis and Fanconi syndrome may be the most prominent and perhaps the most common, there are a number of other conditions that require distinct and different treatment. With that, I would like to thank you for your attention and would be happy to take any questions.